Estamos a disposición de ustedes para lo que necesiten. Se me complica hablar un poco en inglés, así que ustedes díganme y yo les estoy aquí para ustedes.
We have many translators on the phone who can translate for you. Tenemos muchos que pueden traducir, no se preocupe.
Okay, thank you so much.
Hola, Ricardo.
Hey, mi charla está en castellano también, o sea que...
Santiago, you should be the interpreter because you know him and you can translate better.
I can. I guess I got confused. I did my talk in Spanish. I thought that everybody wanted to practice their Spanish.
We will do whatever you provide us.
I can do it. I can let you guys read the Spanish, and I'll do it in English.
Daphne is in charge, though. Daphne is the.
Well, we thought it would be nice. We thought it would be nice to have some talks in Spanish, so Santiago did the right thing.
Santiago, yo en cambio lo he hecho en inglés. Pero lo voy a decir en español.
I can leave mine in Spanish so that you guys can read Spanish, and I'll do it in English. Whatever it's. I feel more comfortable doing medicine. This is weird, but I feel more comfortable doing medicine, especially cardiology, in English than in Spanish.
Well, if you have it written in Spanish, that's really helpful. I think you're right.
Yeah.
Santiago. So that's great. So I think, Margaret, we probably can get started, right?
I think so. Betsy should be here in about 5 or so minutes, but I think we are good to go.
Okay, well, I want to welcome everybody to our fourth, I think, our lecture series for Heart Care International. Well, nice to see our friends from all over, and I'm glad we can do this virtually. Today, our topic is interrupted aortic arch. And we have a team approach. Dr. Santiago Borasino from the University of Alabama is going to speak about critical care. Martine Bouzi is here to speak about the nursing care of the patients after interrupted aortic arch. And David Montoya is going to give us a cardiology perspective. And he's one of our colleagues from Peru. And I think that Ibrahim Abdullah is going to join us hopefully soon, and he can give us a little surgical perspective as well. Why don't we start? David, do you want to start, since it usually does start with the cardiologist?
Okay, I will present the case. I don't know if, would you prefer try to do in English, or you can, I can do it in Spanish, and
you do it in Spanish, and we'll just follow along. Do you have slides? You want to share your screen?
My slides are in English. Yes, I have some slides.
Okay, the slides in English and speaking in Spanish. This is perfect. This is perfect. We have. So if you want to share them, that would be so great. And then, Ricardo, we thought you'd speak at the end. So if Roberto can listen, or he can play a little bit and come, and you're welcome, of course, to stay and listen.
Listo, ¿puede verse?
Perfect.
Ok, muchísimas gracias por la oportunidad. Voy a contar un poco la historia de cómo conocí a Roberto. Hace un tiempo llegó específicamente en noviembre de 2015, mientras estábamos en la mitad de la campaña Heart Care International. Un neonato de unos 5 días de vida. Había nacido por una cesárea porque, bueno, ya tenía 42 semanas. Inicialmente en el examen no había nada llamativo, no estaba cianótico y el esfuerzo respiratorio era leve. Al hallarle un soplo piden la evaluación por cardiología. ¿Está bien o necesita traducción? Do you need translation?
I'm sorry, David. No, I think we're good. You can keep going in Spanish.
Really? Do you want I continue in Spanish?
Yes, you can continue in Spanish, David.
Muy bien. Listo. Él fue admitido al hospital Inmediatamente, bueno, en los exámenes se vio el electrocardiograma, un ritmo sinusal, no había arritmia y se procedió a realizar la ecocardiografía. Vamos a compartir las imágenes de la ecocardiografía. Un momento. Esta es una vista del situs abdominal. El paciente estaba en situs solitus. Yendo hacia arriba, el drenaje de las cavas era normal. It has a normal systemic venous drainage. En el centro intraarterial había un foramen oval permeable. In the intraarterial septum there was a tiny PFO. You can see the shunt here. Pueden ver el cortocircuito a este nivel. The ventricle was in a D-loop configuration. Los ventrículos estaban configurados en una posición normal, el derecho a la derecha y el izquierdo a la izquierda. And there was not obstruction in the LVOT. Y no había obstrucción en el tracto de salida ventricular izquierdo. Se puede ver aquí en el eje largo una muy buena función. Las cámaras, a pesar de que inicialmente parecía la cámara, o sea, solamente se observaba una ligera dilatación de la cámara izquierda, auricular izquierda y ventrículo izquierdo tenía una dimensión normal. Here in the plaques, there enlargement of the left atrium, but the left ventricle is still in normal size. The flow across the aortic valve, and then the flow across the pulmonary valve. Y aquí el flujo en la salida del ventrículo derecho y en la válvula pulmonar. Ahora, inclinando un poco se puede ver pues que hay algo raro en esta pulmonar, no se divide de la manera en que debía dividirse.
You can put on whatever you want to put on.
Are you going to be watching that? I can watch something that you don't want to watch.
Y en esta vista de la pulmonar se puede ver pues, que no se divide de la forma común, ¿no? Es más, tiene una extensión a ese nivel hacia lo que vendría a ser la aorta descendente. Una vista un poco más de profundidad, se ve la continuidad de la pulmonar por el ductus y la aorta descendente. In increasing the deep in the view, you can see the pulmonary artery, the PDA to the descending aorta. With the color, you can see bidirectional flow across the PDA. Y se puede ver un flujo direccional a través del ductus arterioso. Se ve aquí en el patrón Doppler. Tenemos la vista del eje corto, la contractibilidad de ambos ventrículos es bastante buena. In the short axis, the systolic motion of both ventricles is good. And also we can see that in the 4-chamber view. Y podemos ver lo mismo en la vista de 4 cámaras, ¿no? Una buena contractibilidad. Había una regurgitación mitral muy leve y una regurgitación tricuspidia que nos mostraba una presión muy alta a nivel de la cámara derecha y por consiguiente la arteria pulmonar. And there was a tricuspid regurgitation with a high velocity. It means there is a high pressure in the RV and also in the pulmonary artery. Okay, let's see here. You can see here the pulmonary artery and use the RPA. There is a communication between the RPA with the ascending aorta. Viendo aquí, esta es la arteria pulmonar y podemos ver la rama derecha y hay una comunicación entre la rama derecha y la aorta descendente, que se correspondería a la ventana aortopulmonar. Una vista un poco más centrada en ese fenómeno, cómo se comunican ambos vasos. Y en la vista del arco aórtico, no se ve una continuidad del arco, ¿no? Se ven, después del nacimiento del tronco brachiocefálico y la carótida izquierda, se ve una discontinuidad And in the aortic arch view, you can see there is an interruption just after the before the left subclavian artery. And we move, and when we move the probe, we can see the distal segment is in is just joined with the pulmonary artery by the PDA. Y se puede ver al movilizar el transductor que el segmento distal, la aorta descendente, está unida por el ductus arterioso a la arteria pulmonar, lo que vendría a ser el arco aórtico interrumpido. Y esta es una vista yendo desde los planos valvulares donde se ve justo la unión, ¿no? Vamos a detenerlo aquí. Están la aorta y la pulmonar. This is a view used from the plane of the semilunar valves, the aortic valve and the pulmonary valve, and just going to the head, you can see this union between the trunk of the pulmonary artery with the ascending aorta, and then the origin of the RPA. This is the configuration of a aortic pulmonary window type 3. Y se puede ver en esta vista yendo hacia arriba la unión entre el tronco de la pulmonar a este nivel con la aorta ascendente y luego posteriormente el nacimiento de la arteria pulmonar derecha de la aorta ascendente, lo que vendría a ser la configuración de la ventana aortopulmonar tipo 3. Con esto había una combinación para patología en este bebé de una interrupción del arco aórtico tipo B con una ventana aortopulmonar tipo 3, que es bastante rara, una configuración bastante rara. With the findings of the ultrasound, we can see the baby has an aortic arch interruption type B and an AP window type 3. This is a configuration very, very rare. It's not usually to see this combination. The baby also has an CT scan. It was performed in another health institution. I will try to share my window. Here, this is the CT scan. In this plane, you can see use the image in the ultrasound, the aorta, the aorta and the pulmonary artery, and you can see the joint here at this point, and at this point, just to define the AP window type 3. Y en esta imagen de la tomografía se puede ver justo esta configuración a nivel de los vasos. La aorta y la pulmonar, se ve la unión justo a este nivel entre el tronco de la pulmonar y la aorta, y entre la rama pulmonar derecha y la aorta, lo que es la configuración de la ventana aortopulmonar tipo 3. Y en este plano, vamos a tratar de modificarlo un poco. Para tratar de reconstruir lo que vendría a ser la interrupción del arco aórtico. No tenemos una muy buena imagen, pero aquí se ve justo el segmento proximal, la interrupción y el ductus que continúa, comunica con el segmento, la aorta descendente con la arteria pulmonar. Sorry about the quality of the image. You can see here an image of the arch. This is the ascending aorta and the zone of interruption and the continuity between the pulmonary artery with the descending aorta by the PDA. With these findings, the case was presented to the HCI team to proposing a surgery. Con estos hallazgos, bueno, presentamos el caso al equipo de Healthcare proponiendo una cirugía correctora. That was all used for the moment. Eso sería todo por ahora.
It is a pretty amazing case and a beautiful presentation, David. Thank you so much. I was wondering, did Ibrahim do this case? Was he the surgeon on the procedure?
Yes.
Are you on the phone?
Yes, I was just able to log in.
Oh, fantastic. Nice to see you.
Likewise,
So
thank you.
maybe we could go to you and what kind of considerations you have for this surgery. You know, this topic is interrupted aortic arch, but we have a very complicated, rare lesion where you have not only interrupted aortic arch, but you've got an aortopulmonary window, which certainly helped the circulation pre-surgery, but must have complicated your ideas post of your intervention. So what were you thinking about?
So, so this was actually my first time with HCI, so I wasn't really sure what what our capabilities were as a team in Lima, Peru, and we thought of several options. One option was to do a complete repair, and another option that we were that was on the table was a hybrid type of an approach. Essentially, if someone were able to stent the ductus, and we would be able to band bilateral branches and let him get through with time for an eventual complete repair down the road. But it just happened that I had some set of neonatal cannulas with me at the time that I had joined the team for the trip, and we had a discussion about the going forward with the complete repair. And after a bit of convincing with Rob and the team, I think we made the right choice at that point in time and decided to go with a complete repair. Sorry, I missed the early part of the presentation, but I can talk a little bit about the surgical considerations.
Yeah.
Okay. Now, unfortunately, I had a few slides that I could have shown from my computer, but I can't connect to the computer. But a couple of things that in a complete repair, I think from a surgical standpoint, we have to pay attention to what our perfusion strategy would be for this for the young child. You want to make sure that you're perfusing both the ascending aorta as well as the descending aorta because of the interruption that exists. And there are a couple of ways to do that, or a few ways to do that. The other thing that you want to have in the back of your mind is what kind of a strategy would you employ? Would you employ a strategy that would involve cooling the child to deep hypothermia and doing the crux of this repair under circulatory arrest? Or would you consider a strategy of antegrade cerebral perfusion, selective antegrade cerebral perfusion, where you're just perfusing the upper body, the brain? Or you consider total body perfusion during the time that you're doing this repair? And the strategy that we went with was a total body perfusion strategy, so perfusing both the upper and the lower body, throughout this repair. We ended up cannulating the innominate artery and the descending aorta above the diaphragm to have flow to the lower body, and then we divided the ductus during that perfusion time, and essentially when we cross clamp, we also have to snare the branch PA so that we wouldn't flood the lungs during this period of time. But we arrested the heart, and the way we dealt with the interrupted aortic arch repairs, when we divided the ductus, I believe this was a type B, we connected the descending aorta directly to the ascending aorta. But the way we dealt with the AP window was, if you could imagine that RPA as it was going behind the ascending aorta, we did a transverse aortotomy above the level of the RPA, so above the superior margin of the RPA and below the inferior margin of that RPA. So essentially you have a donut of anterior aorta overlying that RPA. And we basically used that flap of aorta to plasty the RPA and then brought the two ends of the ascending aorta together. So that was our strategy.
And the decision to do the total body perfusion was because it was going to take you a long time to do the surgery. You felt you needed to perfuse both the upper and lower body.
Well, I think this was one of the things that allowed, and I apologize, I don't have the op-note in front of me, was that it allowed us to keep the temperatures a bit higher, so that we would potentially see less of the coagulopathy associated with deep hypothermia. And
that was your idea for post-operative care. You were hoping to avoid some of the post-operative morbidities then.
Yeah, some of the bleeding issues that we would potentially encounter due to the coagulopathy. But you're correct. I think this could have very well been done with a perfusion strategy where we could have cannulated the innominate artery, and then we could have also cannulated either the MPA or the ductus and cool down to an appropriate temperature. Generally, deep hypothermia, we think about 18 degrees, but if we're just concerned about the lower body, we can probably go down to about 25 degrees if we're maintaining flow to the brain with the selective antegrade perfusion. So,
Ibrahim, that's tremendous recollection of what was at the time a pretty complex operation. I've been looking on my computer for your drawing that you had done before the operation, and all I can find is the post-op CT scan and the drawing that you did when we went back to enlarge the arch the following year. I can show both of those if you would like, Daphne, but also we should get, I think Bob Dayball is on the call, we should get his perspective on the repair too.
Bob, are you there? Yeah.
Bob, you may be on mute.
He was on the call. He might be distracted.
Okay.
I can, before Bob, while we're waiting for Bob, Rob, if I interject for a moment regarding the choice of the repair, as you may recall, we did a direct connection of the descending aorta, which was a bit proximal to the left subclavian, the barrel, as we connected that end to side to the ascending aorta. One of the things that some of our colleagues talk about is possible tension associated with that, and whether the left subclavian ought to be sacrificed in that process or not. I think we left the left subclavian intact. But one of the things that, one of the potential risks of that direct connection with the subclavian still there is that one may not get all of that ductal tissue potentially removed in the direct connection, and hence there's a risk of later restenosis that we, I believe, encounter. An alternative technique, and I had these slides, I apologize I can't show them, but an alternative technique, and maybe Bob would be able to comment on this, and this is something that I've used frequently in the past, is you open up the, after you divide the ductus and separate the descending aorta from the ascending and arch, you basically open up the descending aorta or distal arch all the way along the medial aspect of the subclavian, the left subclavian. And you do a similar incision along the left carotid, along its leftward aspect, going down towards the ascending aorta. And you bring the subclavian to the left carotid and augment the undersurface of the arch with a patch of one's choosing. And I think the Congenital Heart Surgeons Society data seem to favor that that approach in terms of overall favorability with respect to mortality, but the classic approach of connecting the descending aorta directly to the ascending aorta, I think works well, provided that the ductal tissue is removed in its entirety.
Mhm. I guess.
I can speak firsthand to the fact that it was indeed an elegant and beautiful operation that was performed, life-saving, as we all know. And I'll show the post-operative result if I can share my screen here. And let's see, are you seeing this or not?
Yes, I see it beautifully.
Yeah. So you can see that left subclavian is really a very diminutive vessel and may not have worked in this circumstance, Ibrahim, as you described it. But as you can see there, the descending aorta is really quite a good large vessel. The ascending aorta was somewhat narrow, and as a result, Ibrahim did a repeat operation the following year, which again I was able to witness, and this was the plan. That's his drawing, and then here you can see how he patched it.
Okay.
Right.
So this had an aberrant right subclavian as well, it seems like it.
Yeah, that was part of the
Yes.
that was part of the work in just terms of mobilizing that so that we could get the descending over to the ascending, remember?
Right, correct. Right.
Beautiful result.
I'll turn it back over to you. I'll stop sharing here, Daphne.
Yes, I think, why don't we just go on to Santiago? I think you're going to talk about the ICU management of patients who are coming out of such a complex surgery and how you think about it. And I think you
Yeah,
could
I
share-
can start sharing once.
Yeah, how do I stop sharing, Daphne? Anybody?
Usually at the top, Rob, it usually says, or at the bottom. At the bottom, it should say stop sharing if you hover. As we share screen, it'll say stop sharing at the bottom of your screen. Let me see.
I'm sorry, everyone.
Yeah, it's down near the bottom.
Oh, I got it. Thank you.
Great. There you go.
And I think we lost Dr. Dable somehow. He's not answering my text messages either. So
He's a busy man, I'm sure. So go right ahead.
okay. So I'm gonna go in English, and if anybody has any questions about questions in Spanish, please do not hesitate to interrupt and talk. What I'm liking a lot about this session so far is the sort of casual, friendly nature of everybody who's talked so far, and I love it. So I'm going to try to keep it. So what we're going to talk about, I did an overview. I was not part of the treatment of Roberto, so I can't speak of that particular case, but overview of the ICU care of the interrupted aortic arch, from a little bit of a pre-op preparation, sort of like standard, what you would expect coming into the unit. And I'm going to use what we do in our unit. And ICU care, I've learned in 13 years, is that it's full of isms, and everybody has their own style. And I really cannot tell you that one style is better than others. They've been built in every single program through the years, and it works for those teams. And it works. Sometimes you steal a little bit from here and there. Unfortunately, especially for lesions that are not very frequent, there's no randomized controlled trial to really know what's best for specific lesions. So we really hang on to our isms. So the disclosure here is I don't mean to say that the way that I'm going to talk about is the only way to take care of an interrupted arch, or like the way our style is the only style to use. So with that disclosure, we're going to just talk about standard management, some complications, and then residual lesions. In the operatory stage, you really want these patients ideally to be diagnosed prenatally, if possible, but if not prenatally, at least really soon after birth, because you want them to be as stable as possible. You want them on a all of them are going to need prostaglandins, because the only way the lower body is going to get blood is through the open PDA, which Dr. Montoya showed very, very nicely in the CT scans. It was still open. But that doesn't happen all the time. And in the setting of Peru, it might happen more often that these kids actually present in severe shock. And having a high index of suspicion by the emergency room or the neonatal unit that they might be dealing with a heart patient is what really makes a lot of a difference. Because as soon as you can start the prostaglandins, the sooner you can start the recovery of the patient. So assuming that the patient shows up very, very sick, you start the prostaglandins, and then your job is to try to recover the organs as much as possible. You're going to have potentially liver injury due to high end diastolic pressures and central pressures in the heart. So you can have a shock liver. You can have kidney failure with high creatinine, high BUN due to the decrease in the lower body perfusion. Obviously, lactic acidosis and shock in general. These patients are probably going to be intubated as part of their initial stabilization as you are looking for the diagnosis. So that's one of the things that you want to try to do. You want to try to extubate them as fast as you can, but not before they're completely recovered. And then the controversial part for us in the ICU is, what's the ideal time for the operation? In both the complicated patients and the uncomplicated patients. And I've been part of a group. This paper has not been published yet. We're sending it as an abstract to the American Heart Association. But out of the PC4, which is a large group that collects data all together, we've tried to analyze both complicated and uncomplicated patients to see if there's any data that supports, you do surgery before 7 days, you do surgery after 7 days, and the reality is we found no signal. It's not a perfect study, but to me it means two things. One, it's either there's really not a perfect time to do the surgery, or B, the study is reflecting that the decision making on a patient-to-patient basis of the centers that participate in PC4 is correct, and we're choosing the right time to do the surgery. We're not delaying, we're not accelerating it. But bottom line, what we will do in Birmingham will be to try to let this patient, if it presents with shock, let this patient recover completely, ideally extubated, and then we set a time for the surgery. And if Dr. Dable returns to the call, he can have an opinion about that too. So what do we do? The patient goes to the operating room, has a very complicated surgery, like Ibrahim described, with potentially hypothermic arrest, or the circulation to the upper body and to the head, just like he described. Basically, you're going to get a patient that's going to be intubated. The first thing you need to realize is that is important is where your arterial line is. If the arterial line is in the right upper body, because there was work done in the arch, and one of the unfortunate main complications in this, and the surgeons can talk about it, it's hard when they work in such small vessels. Even the aorta is small in newborn. You can have residual coarctation even from the get-go. So having an arterial line in the upper arm compared to a femoral line or umbilical line, it's important to kind of set your brain that you might be seeing higher blood pressures if there is residual, or the heart might be seeing high blood pressure if there is residual and your arterial line is in the other side of the obstruction. So knowing if there is some residual, and you may know that from the TEE, but also remembering where your A line is important every time your surgeon works in an arch, especially if it's a complicated arch like this one was. I mean, Ibrahim was working on the window and he was working on the arch. So both surgeries can potentially cause a residual. Now, the window was below the right upper extremity blood vessel, so that would have caused a residual obstruction before either A line. So that would have mattered, but the one on the arch could have. These patients, depending on how complicated the procedure was, how long, how much bleeding there was, they may come with the sternum open or the sternum closed. And basically, if the patient comes in the sternum open, there is some advantages of it because the hemodynamics are going to be a potential risk for infection. The advantage for the patient is you can go on ECMO faster if you have ECMO. The disadvantage of the patient is that things are exposed. Again, the same thing. And then another advantage for the patient will be depending on how long the patient stays open. I don't know, what you guys do, Ibrahim? Did Roberto stay open, or did you guys close him?
No, we elected to leave him open. His chest was left open post-op.
We have done a big trial again with PC4, no big trial, a big study with PC4 looking at acute kidney injury. And one of the things that we found, and we were surprised, was that leaving the patients, neonates open, was actually protective for acute kidney injury. So there is a benefit from the hemodynamic standpoint to leave a patient open on the first night. And as an intensivist, if it was a big complicated case, I'm sort of happy when the patient is left open because I know that I'm going to struggle a little bit less. Our usual combination of inotropes in our unit is milrinone on almost everybody, low dose epinephrine and low dose vasopressin. We looked at our data a long time ago. This was before everybody was excited about vasopressin in the cardiac world. And we found that even a small dose of prophylactic vasopressin was good for our patients with better results. So we like to have it even if it's just a minimal doses. I think that in my opinion, you're better off preventing low cardiac output than actually desperately treating low cardiac output syndrome. So I like to keep my blood pressures a little bit on the high normal side rather than letting them like drift down, even if it means a little bit more inotropes. An important association of the interrupted arch in arches in general is the George syndrome. So these patients are going to need a lot more calcium. Roberto didn't have any genetic abnormality, but it will be unusual to know this early on that somebody has the George, because most of these patients get surgery in the first week of life. We also did a small pilot randomized control trial where we gave hydrocortisone to all of our patients, and we've continued, and it did decrease the incidence of low cardiac output. Again, the same idea that preventing low cardiac output is better than desperately treating it. So we do this on everybody, and it's worked good for us. Anybody less than 5 kilos that has surgery gets an infusion of hydrocortisone, and it's not as immunosuppressive as methylprednisolone, which we have stopped using, or dexamethasone, but I think that it does replace the cortisol levels on a few patients that do get cortisol deficiency. So we do that on all our patients in Birmingham. The fluid management, we have an aggressive fluid restriction management. All of our patients only get 1 ml per kilo per hour of D25 as the only fluid other than the fluids necessary for care, infusions, and those kind of things. If the patient is less than 2.5 kilos, had a creatinine of more than 1 before the surgery, open sternum, and if the surgeon elects to, those patients get a peritoneal drain. And for us, anybody who gets a peritoneal drain also gets peritoneal dialysis. And I think there's buildup of data that support that doing peritoneal dialysis on complicated patients improves outcomes. We used to do it on a lot more patients than we do now. We're trying to find out, because definitely not absolutely everybody. If Roberto would have come out close and doing great and the surgery did good in the OR, putting a peritoneal drain could have delayed his surgery, exposed him to one more drain. So we don't believe that absolutely everybody needs it, but we're still trying to fine tune really who will benefit from the peritoneal drains. The few times when we don't put one in, and the patient gets really swollen and the fluid management becomes complicated, we've sort of regretted it. So it's something that we're working hard on learning more about, and hopefully we can continue to publish data to help on this decision making. Lastly, another thing that is pretty standard is sedation and pain. If the patient is open, our combination is dexmedetomidate and fentanyl drips. If the patient is closed, we try to avoid the fentanyl drip and just leave it on dexmedetomidine, because in general, our goal will be to try to extubate the patient by the next day. So complications. The low cardiac output syndrome is probably one of the most important ones. We try to keep the central venous pressure at 8 to 12. You adjust inotropes as much as you can. You keep the patient sedated. In this previous slide, I mentioned dexmedetomidate and fentanyl drips for the open patients. We don't regularly paralyze them, but this is a situation where you might need to paralyze the patient. And of course, if things get really, really bad, ECMO. I have a picture here of our lead perfusionist, Joey Timpa, who also goes on Heart Care International trips, so you guys might remember him. Another important complication is bleeding. Ibrahim talked about the coagulopathy that comes with doing cardiopulmonary bypass cases and severe hypothermia in neonates. It's important. It can be severe. What we do in Birmingham is what we call our protocol. Basically, measure the chest tube output every 15 minutes and replace it with 50% of that volume in packed red blood cells, 25% of that volume in FFP, and 25% of that volume in platelets. We only activate that on anybody who's bleeding more than 10 mLs per kilo per hour on a 15-minute adjusted time. And we've had great results. I don't have any randomized, we don't have any comparison group for this. This is something we just started doing. And one of the things that I love about it is that it replaces the coagulation factors really well. The only thing you have to remember is occasionally we measure coagulation studies every 2 hours and adding some cryoprecipitate. But in general, it also keeps the patient extremely hemodynamically stable because you're replacing volume by volume. 100% of the volume that comes out in the chest tube is being replaced 100% volume of a combination of products. and the nurses adjust it every 15 minutes. So you don't get behind. You don't get more coagulopathy if you end up replacing too much packed red blood cells and not too much products. So I really think this makes the care of these patients a lot easier, because as an intensivist, I don't have to think about transfusion. I'm just taking care of everything else, because I know the transfusion is being taken care of by the data coming out of the patients every 15 minutes. And for whatever reason, and I wish I could, I'm trying to figure out how to collect the data, to present it and to prove it. I feel like a lot of our patients who come out bleeding a lot get a lot better with this protocol, and Bob can probably talk. He's a really big fan of it. High blood pressure can be the other problem whenever you work with arches, and nitroprusside, nicardipine are the drugs of choice for us. This is a patient that's going to may or may not have a VSD. In this case, there was no VSD, but there was a aortic window. But when you have a VSD, you can have junctional ectopic tachycardia. You can have heart block. Patient's going to come out with wires. I personally utterly hate junctional ectopic tachycardia. It's terrible. It's painful to treat. It makes the patient so much more unstable. The ideal treatment includes beta blockers, which you don't want to use in the middle of like in the night of a post-op. Amiodarone works, but amiodarone has bad side effects when you bolus it. We have actually moved to using a lot more procainamide with good success. You do need to have procainamide levels, which we recently started doing. And I've been happy with what procainamide has brought to our center. So, but I still hate jet. Dexmedetomidine can help you, but in the bad cases, it's not enough. The next thing that happens if your patient is having a lot of problems, or if your patient is having prolonged convalescence, that means that if they're staying sick for longer than you expect, is to look for residual lesions. One residual lesion is a residual VSD. Another residual lesion that we talked about is the gradient across the aortic arch. One of the most important complications of residual lesion in this particular patient will be left atrial hypertension. That can be from the residual VSD. That can come from the gradient across the aortic arch. But also some of these patients do have small left-sided structures. And if you have a small ventricle, if you have a small mitral valve or a small aortic valve, you can end up with left atrial hypertension that is reflected in pulmonary edema, pulmonary hemorrhage in its extreme form, or just low cardiac output that just doesn't get better, sort of stuck on inotropes. So whenever your patient is not progressing the way you think, you need to start thinking, is there something wrong? Echocardiography helps a lot, but ultimately you might need to go to the cath lab. Diastolic dysfunction, of all these things, diastolic dysfunction is the one that is really hard to manage, because there's really no other way but to wait for it to get better. You don't want to undo the surgery in any way if it's just diastolic dysfunction, and you just have to excuse the term, but suck it up and wait. It gets better over time. But for the intensivist at the bedside, to just be day in, day out with a patient with diastolic dysfunction is hard. Other complications that are late, and by late I mean a few days, but that for intensivists is a long time, is you can have vocal cord paralysis when you extubate them. You can have chylothorax when you start feeding them. And for whatever reason, and I don't think that this is exclusive to the University of Alabama at Birmingham and Children's of Alabama, is that a lot of these neonates that we treat for congenital heart disease have problems with feeding, even if their vocal cord works. And we really don't understand. Personally, I think that maybe passing a big TEE or the intubation might be playing a big role, in some kind of mild injury to the laryngeal muscles that doesn't let them eat very well. But bottom line, our center's rate of needing nasogastric feeding or G-tube is about 30% for neonates, and I wish it was lower, but I don't know how we get it lower. And that's all I have. Any questions or comments, or what other centers do?
Thank you, Santiago. I thought maybe we'd do Martine's presentation because it kind of pairs with yours very nicely, and then we can do the questions afterwards. Does that sound all right?
Okay, great. All right, bear with me here. Let's do this. Are you able to see the screen well? Let's see.
Not yet, Martine. But
Okay. All right. Let's do this.
there we go. That's great.
Okay, perfect. All right, great. All right. All right. Santiago touched on a lot of some of the things I'm going to talk about today, but we'll focus on the nursing aspect. So the proper admission of a post-op cardiac patient, who we'll talk about general post-op recovery from the nursing perspective, and then narrow it down to specifically interrupted aortic arch. But it's a highly structured and organized process for this critical care patient. Usually 2 nurses are assigned to the patient, and 1 nurse is the assigned patient nurse, and the second nurse is really there to help with lines and blood work and some of the documentation. But this involves a very coordinated systems between multiple services to transition the patient safely from the OR to the critical care setting. The primary nurse job is really to get the room ready. And what I gathered from Santiago's talk is how critical this patient is going to be post-op, right? Critical going into the OR and critical, even more critical coming out. So, it's likely to be a neonate, right? We're doing surgery within the first week of life. So likely to be under 5 kilos. So the baby's going to be on an infant warmer. Important to have emergency drug sheet that is weight calculated in the room, intubation equipment, the ventilator. If you looked at some of the pictures, some of the schematics of the interrupted arch, this lesion is ductal dependent, and the RV is doing a lot of the blood flow to the distal aorta. So the patients have a lot of pulmonary overcirculation and can have some pulmonary hypertension post-op. And so nitric being available in the room is important. Suction of usual cables, hemodynamic lines. Santiago talked about some of the arrhythmias, post-op jet, heart blocks, or having a pacemaker box in the room, the appropriate pumps, and some of the cardiac meds and drips that we're going to anticipate needing post-op. So the handoff is very critical. It's standardized in many institutions. And so the players who are there at the handoff, you'll have the surgeon and whoever he designates to give sign out. It could be an NP, a PA, or CT fellow. We have our cardiac intensivist and his fellow. Some places have general intensivists and then have the cardiology team there. And then the nursing staff will be there. And the first nurse, again, is assigned to the patient, is going to admit this patient and the second nurse has specific limited responsibilities assigned to help stabilize the patient. So it's anesthesia and the surgeon who are giving the sign out. Anesthesia usually gives you the some of the pre-op history, right? Patient's name, age, weight, brief history of the diagnosis and pre-op course. Surgery will talk about the procedure performed, what they found in the OR. Dr. Ibrahim talked about the anomalous blood vessel that Ricardo had and how it impacted surgery and what they had to do in the OR. You'll get the total bypass time, circle rest, cross clamp circle rest. Did they do regional cerebral perfusion? Complications coming off pump. Was it easy to come off pump? Did they leave the chest open? Did they need to escalate some of the drips because there was trouble coming off pump? And then the post-op TEE, we had interrupted arch. The arch was reconstructed. Is there any gradients across the arch? And how severe is the gradient? And all will impact really what's happening post-op, even for nursing, in terms of what to watch out for from the vital signs, any residual defects that's going to give you trouble in the immediate post-op period. Anesthesia will talk about some of the blood product administration, invasive lines. Does the baby have transthoracic lines? What are the cardiac drips? Vitals in the OR before leaving the room. What's the rhythm before leaving the room? Usually I help transport the patients from the OR to the PICU. So I always watch what the vitals are before we leave, and then what it is when we get there, to look for subtle changes within just, the transport. So in the PICU, we're monitoring heart rate, blood pressures. Santiago talked about having 2 A lines, right? So a repair A line and a post repair distal blood pressure measurement. So this Ibrahim, it may have worked too much. So the baby had an anomalous right subclavian, but getting a right radial A line and a leg blood pressure to monitor for gradients and for changes as well. And then the temperature, very important, because hypo or hyper can affect hemodynamics. If you're, febrile, right, it may precipitate the jet. And if you're hypothermic, can cause some clotting issues and promote bleeding. Some patients will have PD drains in our, at Cohen's on our team. We put the PD drains in the OR. I work at NYU as well. They tend to put it in the ICU. The nurse practitioners will put it in if a patient needs it. We put it prophylactically at Cohen's. So the second nurse will assist with calibrating the transduce line. They'll send labs, they'll do the documentation, all while the first nurse, primary nurse, is admitting the patient, getting the patient on the monitor and taking report from anesthesia and the surgical team. Physical exam is going to be very important, right? So initially, the patient comes up from the OR and there's 30 people in the room, right? It's a big team who's there to get the report, admit the patient. And, in 15-minute time, 30-minute time, everyone is gone. So physical exam and paying attention to details and subtle changes is very important. Nurses are frontline. And so it is very critical to be aware. I talk about the 5 Ps. And so we'll go through them very briefly about what to watch out for initially when the patients come up. So perfusion is very important, right? Patients should be warm while perfused. should be unmottled, should have good distal blood pressure, should be brisk and full. Now, this is a very sick baby who's likely had a prolonged pump run, prolonged circ arrest if the baby's going to be circ arrested. And so it may not be this pink rosy baby, but paying attention from how the patient arrived and frequent assessment is very important. The baby initially, right, with rewarming could be warm, vasodilated, a little bit hypotensive, may require some volume initially, and then things will change throughout the course of the afternoon and night. And we'll talk about the post-pump slump and what to watch out for. Blood pressure is important. So monitoring for where your systolic blood pressure is the diastolic blood pressure adequate? The coronaries fill in diastole. So it's very important to have appropriate coronary perfusion pressure. Santiago talked a little bit about bleeding, and we just had surgery in the aorta. So we were about suture lines, and we try to keep the blood pressures within a certain range to minimize bleeding around those suture lines, right? Protect the suture lines. So very important to monitor blood pressure and keep it within the parameter that, your cardiac intensivist or ICU doctor is going to ask for. The third P is urine, right? So monitoring for urine output, we want at least, 1 cc per kilo per hour. That may change because this is a patient who, again, may have had a long pump run, circ arrested, may start out making urine, but, goes through the post-pump slump, has like systemic inflammatory response, low cardiac output, and the body's smart is trying to maintain cardiac output, and so holds on to urine. And so the baby may not make urine for 2 days, for 48 hours. And so this is where the PD comes in, come in handy. With the SIRS, you can have some capillary leak and third spacing and ascites. And we put our PDs at Cohen's prophylactically and are very helpful, actually, in terms of collecting the ascites. And when the patient has recovered from that lull, and the urine output will pick up, usually within 48 hours or so, we're removing the PDs in the PICU. The fourth P is P wave, so is the patient in sinus rhythm, and if not treating any dysrhythmia, so jet and heart block. And the fifth P is pleural pericardial effusion, right? Knowing the signs to what for tamponade, very important. Babies' heart don't tolerate stress very much. They get very tachycardic, if cardiac output is compromised. So it's one of the first vital signs to change when there's trouble or the baby's stressed. So knowing where your heart rate started, at the beginning of your shift and looking for subtle changes. So is the baby tachycardic, hypotensive, CVP, started single digit, it's doubled, muffled heart sounds, the chest tube that was draining is no longer draining, or it's, is it clotted up or what's happening? So knowing what the signs are for tamponade. And for interrupted arch, we know high association with the George, right? So hypocalcemic, monitoring all the electrolytes and topping them off as needed, right? Calcium is a positive inotrope, so it's going to be important here to treat any hypocalcemia. Again, the baby may have some pulmonary hypertension, is a setup for pulmonary hypertension. So watching for the signs and how to treat it, with some sedation and oxygen nitric post-op. The recurrent laryngeal nerve is wrapped around the aorta very near where the surgery is going to happen. So high risk for vocal cord paralysis or paresis. And so, once the baby's extubated, listening for any stridor, getting ENC. At Cohen's, we, for all interrupted arches post-op, we get an ENC evaluation soon after extubation to look for any vocal cord issues and, get speech involved if we find any, and encourage feeding orally for sure, and find techniques for sure. And if there's any concerns for aspiration, we'll do NG feeds. Santiago, we have the same issue with a lot of our kids who we're discharging home, of our cardiacs discharging home on NG feeds and G-tube. I was just having a conversation today about this. But a lot of our pre-op kids, if they're on PGE for ductal-dependent systemic perfusion, don't feed pre-op. And so they don't feed pre-op. They have complicated, surgeries. And so feeding is delayed for a week or so. And then so post-op, it's a big problem trying to get them to learn to eat. So it's something we're working on.
We're actually, sorry to interrupt you real quick, but we're actually feeding even the arch-dependent prostaglandin patients. We're letting them eat by mouth.
That's great. That's great.
And we let them limit themselves. If they take 3 mLs, they took 3 mLs.
Yeah.
But we don't know if it's going to improve our outcomes from PO standpoint.
Yeah.
But so far we've had good experience letting them eat. Nobody's gotten sick. No neck. No anything. So
That's
hopefully
great.
we'll be publishing that. But I agree with you. It's nerve-wracking.
Yeah, no, that's great. I'll look out for that paper and bring it over to Cohen's. Also potential for phrenic nerve injury, paralyzed diaphragm. So, for nursing, once the patient is, off positive pressure, right? Looking for work of breathing, is the baby tachypnic, so we'll look at the X-ray and look at the hemidiaphragm. And intervene if necessary. And then recurrent stenosis, right at the site of repair for later on. So monitoring gradients throughout. So intra-op, post-op, and then close to discharge, and then intervening if significant. And that's it. Thank you so much for your time.
Thank you, Martine. That was great. I feel like Roberto has been very patient. So I would like to hear a patient perspective from the family of the little boy we heard about, that Dr. Montoya told us about. And I think Santiago had volunteered to translate. So could we invite Roberto and his dad to say a little something about their experiences? I'm trying to see if I can find them. Did they?
Ricardo, ¿estás ahí? Ricardo? Let's see. I saw him earlier.
So patient, he was on.
I know he was on. Let me call him.
All right, so while we're waiting, if people have questions, let's have a talk about this complicated post-operative course, which is very impressive for heart care to have been able to do. Wonderful, such a nice result. Anybody having particular questions for Santiago, Martine, David, or Ibrahim? So Martine, how does the team work in the ICU? Do you round every day? Do you round every hour? What do you do?
¿Estás entrando? Okay, perfecto, gracias, bye. He's coming on.
Okay, good.
He just got thrown off by But
The
the
internet.
internet. So
The internet, yes. All right, we'll wait for him to come. But Martine, how
Absolutely. So at Cohen's, right in the PICU, there's 20, it's a 26 bed ICU. And so they cohort because it's not a separate cardiac ICU. They do cohort all the cardiacs together. There is 2 separate teams, very similar to Monty. And so there is, we call it the blue team for the cardiac patients. And there's about 3 cardiac intensivists who round on the patients and a couple general intensivists. And I work with CT surgery, so I'm very involved. I'm there every day. And we do lightning rounds, similar to what we used to do. So in the morning, about 7:30, the surgeon, our CT surgery and Ps and the ICU do lightning rounds on all the post-ops. And we talk about just a general plan for the day of, what we're doing in terms of what drips are we weaning, what lines are coming out, and who's getting extubated that day. I go in the OR, I first assist, so I will pull lines right then and there if the plan is to remove them. And I don't first assist all the time. So if I'm not in the OR, then I will do regular work rounds with the ICU and, communicate any information to the surgeon if, patient status change. But the team is, it's pretty big. If it's a general ICU doctor who rounds, cardiology will round with us as well. And it's great. And then the post-ops usually come, mid-morning or late morning. And, we cover them, generally kind of similar to what I talked about. So 2 nurses assigned to the patient. We go back and forth. We just hired a second NP at Cohen. So that's why I'm saying we, but we go back and forth between the ICU and the OR, and we'll update the OR. So everyone usually is in the room when the post-op is arriving on the unit. Do that.
A lot of close communication, basically.
Yeah, very, very, yeah.
I do think Roberto rejoined. His dad, Ricardo. So, baby Betsy, perhaps you want to translate since I see you on the phone.
He speaks English. Daddy speaks English.
So, Ricardo, do you want to give us a little patient perspective about your experience with this surgery and Roberto in the ICU?
Okay. Please, I need to translate. My English is bad, really.
Sounds beautiful to me. Much better than my Spanish.
Está muy bien, Ricardo. Tú hablo en inglés y necesitas ayuda. Te ayudamos. Pero está muy bien.
Throw in some Spanglish.
There you go.
Spanglish. Okay, this is nice. Okay. I don't know. The first word is thank you so much for your feeling and for the all for my son. He is a miracle. Is really. I think in this moment, her care is done coming to Peru in this time. My son is not here right now. I think this. Right now, I want to talk in Spanish. Todo lo que pasó con Roberto fue muy fuerte. Muchos de nosotros en la casa, cuando nació Roberto, nació por cesárea, cuando él nació rojito. Y mi esposa se da cuenta cuando él quería lactar, pero como que se cansaba. Entonces, hablamos con el pediatra y él le mencionó al cardiólogo que dio el resultado de que él tenía el problema cardíaco. You understand?
Sí. So, do you want me to translate that or is everyone okay? Is everyone okay?
Betsy. Yeah, you keep going.
Sigue. Sigue. La mayoría de gente habla español.
Okay, good. Entonces, lo único que hice cuando el médico nos dice el problema que tenía fue llamar a todas las personas que yo conocía, porque conozco personas en el Hospital del Niño de San Borja, en INCOR, en diferentes lugares. Entonces, entre todas las personas, el doctor Mogrovejo, que es el director de una clínica aquí en Perú, me contactó, me dijo, tráelo mañana, y al llevarlo, lo iban a anestesiar, y el doctor Niño de Guzmán, que está aquí presente en el grupo, gentilmente se acercó pendiente del caso. Entonces, el anestesiólogo, son milagros, son cosas que suceden. El anestesiólogo no llegó a tiempo, entonces no se decidió por hacerle la tomografía en ese momento. Después de eso, al día siguiente lo trasladamos a una clínica, y en el Perú, hasta donde yo sabía, habían 3 especialistas de cirugía de corazón: el doctor Niño de Guzmán, del INCOR, el doctor Arboleda y el doctor Latorre, que veían temas complejos. Entonces, recuerdo muy bien esa noche, el doctor Latorre y el doctor Arboleda, en la noche después que le hicieron el examen, me dice, siéntate. Y yo le dije, no, lo quiero escuchar parado. Y es ahí donde nos dicen de que ellos no tienen, no tenían la forma de poder hacer la cirugía completa, que podían intentar, pero el riesgo era muy alto. Se me vino el mundo encima. Y recuerdo que esa noche yo me senté junto a mi suegro y le digo, ¿por qué Dios nos deja de lado? Y llorando. Y no miento, pasaron 5 minutos y la amiga de mi esposa llama diciendo de que había una campaña quirúrgica en el lugar donde yo había hecho otra campaña. Entonces, que intentara. Y el doctor Arboleda y el doctor Latorre me dijeron muy gentilmente de que al día siguiente me esperaban a las 8 de la mañana en INCOR. Y la persona con quien hablé fue la doctora Eneida Melgar, y ella me dice, te espero a las 8 de la mañana en el Hospital del Niño para ver qué se puede hacer para que vean el caso, solamente para que vean las imágenes. Yo tenía 2 decisiones, ir sobre seguro o ir a ver si es que qué pasaba. You understand in this moment? Yeah, okay. Y después de eso, yo dije, INCOR, Hospital del Niño a ciegas. Y Dios me dijo, anda al Hospital del Niño. Fui al Hospital del Niño y me acuerdo que cuando llegué a las 8 de la mañana, sale la doctora Melgar y me dice, Ricardo, sé quién eres, dame el CD. Se lo di. Estaban llegando justo el equipo de Haircare y me dice, espera, y viene el padre Johnson, ¿ok? El sacerdote del grupo, y me mira y me dice, ¿qué pasa? Yo le dije, padre, perdí la fe, y me dijo, él no perdió la fe en ti. Y yo, ok, pero yo estaba mal. Recuerdo que viene la doctora Melgar, me dice, toma el CD, después lo van a ver. Y yo dije, ok. Luego viene David Montoya, veo pasar a David junto con Ibrahim, que es mi hermano, en serio. Es una persona increíble. Y viene David y me dice, ¿tú eres el papá del bebé? Y yo le dije, sí. ¿Está aquí? No. dame el CD, el doctor lo quiere revisar de nuevo. Se lo entrego y yo ya no tenía esperanzas, yo dije, tienen una programación, sé cómo es este tipo de trabajo de campañas y es difícil. Luego viene Ibrahim y, o sea, todo el equipo son ángeles. Y Ibrahim llegó así como el ángel principal y llegó y me dijo, ¿sabes qué? ¿Tienes una hoja de papel y un lapicero? Y yo dije, sí, aquí está. Y me dijo, esto es lo que tiene tu hijo, esto es lo que vamos a hacer. Tráelo para operarlo mañana. Cuando me dijo eso, o sea, fue increíble, absolutamente increíble. Y recibimos todo el apoyo del Hospital del Niño. Luego vino Betsy, me acuerdo, y me dijo, ¿sabes qué? Trae al niño, ¿dónde está? Y yo le dije, está en una clínica, tráelo, mañana lo vamos a operar. Y yo, ¿en serio? ¿De verdad? Y me puse a llorar, o sea, no podía más. Y veía a los niños que ingresaban, a las madres que esperaban las cirugías, que hasta ese momento era un día martes, me acuerdo. Y, o sea, y yo estuve ahí del otro lado, con un tema de ayuda también, pero en ese momento pasé de ayudar a ser ayudado. Y fue muy fuerte para mí, o sea, saber de que la cirugía de mi hijo era una cirugía que había muchísimo riesgo y era darle el soporte a mi esposa, o sea, todo el tema fue muy fuerte. Y saber sobre lo que ellos hacían y sobre lo que ustedes hacen y todo eso fue increíble. Entonces, después de eso llegó el miércoles y me dijeron, no vamos a operar a tu hijo. Y yo, ¿qué? Y me dijeron, no, lo vamos a operar mañana, porque el doctor Ibrahim está en una cirugía y quiero operarlo con todo el equipo totalmente consciente y tranquilo y fresco. Y yo, ok, la cirugía fue el jueves. Y cuando hicieron la cirugía, fueron horas muy duras, muy fuertes. O sea, era ver de que salían, ok, voy a contar algo. Salían las enfermeras que me conocían y me decían, Ricardo, tranquilo, van bien. Y después una doctora salía, una doctora peruana, y me decía, tranquilo, vengo a contarte, pero tranquilo, todo está bien hasta ahora. Hasta cuando vi a Ibrahim llegar, o sea, y era como que todo se apagaba y solamente era Ibrahim iluminado. Y me dice, ¿ya operamos? Todo muy bien. Y tu hijo, hay que esperar, pero tu hijo salió bien. O sea, y fue hasta ahora, Ibrahim lo sabe. O sea, yo lo veo a él y lloro, porque es muy fuerte, y cada vez que lo veo a Roberto yo sé que sin desmerecer a los médicos peruanos, ojo, conociendo la historia de lo que pasó con Ibrahim, que lo de la maleta, lo del instrumental y todo eso, fuera de eso, es el expertise y la experiencia que tienen todo el equipo de Healthcare, porque fue desde los muchachos de logística, de apoyo, que ayudaban a Betsy, hasta el cirujano principal, pasando por los anestesiólogos, pasando por los intensivistas que estaban al pendiente de todos los niños. Y hay muchos niños que padecen, o sea, son pocos los casos que padecen lo mismo que Roberto, pero se necesita más, o sea, y si Herker no existiera, si no existiera el equipo de Betsy, si no existiera cada uno de ustedes, el doctor Mischler, o sea, si no existieran, mi hijo no existiría. Es la verdad. Mi hijo no estaría vivo. Y, o sea, es algo fuerte. para mí es súper fuerte. Y yo siempre voy a estar agradecido a HealthCare, o sea, yo me considero parte de HealthCare sin serlo, porque son mi familia. Si no fuera por él, por David, que David sabe lo entrañable que es el doctor Montoya, agradecido al doctor Sofía, a la doctora Zulma, al doctor Álvarez, él fue el que detectó que si no fuera por él, no se hubiera detectado, no hubiera pasado, y Ibrahim, que es mi hermano, o sea, está ahí Ibrahim y lo sabe, y el doctor Misler, que yo le doy un agradecimiento total al padre Johnson, a Santiago, que recién recuerdo que él estuvo también en la segunda cirugía, si mal no recuerdo. Entonces, a todos, a Margaret, a todos, y Betsy, que es, no, Betsy es increíble también, o sea, y es un amor que les tengo a cada uno de ustedes, al igual que mi familia con ustedes, es más. Roberto me decía, Ibrahim, ahora, Ibrahim, ¿dónde está? Debe estar ahí. Y me dice, quiero verlo. Hasta que vio la conversación de Ibrahim por teléfono y me dijo, ajá, ahí está Ibrahim. O sea, es increíble. Sin ustedes, créanme, muchos niños, aparte de Roberto, muchos niños no estarían como están ahora, no mejorarían, porque hay muchos niños, muchos casos que han mejorado por ustedes, por el amor y la fuerza que le han puesto a esta causa, ¿no?
Thank you so much, Ricardo. It's a wonderful story. It really is a wonderful story, and this is why people do what they do with heart care, because they end up with families and friends and long-term relationships. Thank you so much. Now I know the hour is getting late, so I don't want to hold people up from their dinner, both dinners, drinks, friends, family. I would like to thank our speakers, Dr. Montoya, Dr. Borasino, Dr. Abdullah, Martine, Bouzi, and of course, Ricardo and Roberto for joining us tonight. And I hope that if you have any questions, you're welcome to send them along. We'll ask the people who were participating to do this by email. And we hope that you will join us in a month for our next meeting. Anything you'd like to say?
Encantado.
Yes, thank you so much. So
Robertito.
bye, Roberto. Bye,
Hola.
Roberto. Thank you. Any
Muchas
announcements?
gracias.
Mire, esto es Santiago.
Lindo verte,
Hola.
Ricardo. Sí, yo estuve ahí para la segunda operación,
Igualmente,
para la primera.
Santiago.
Yo totalmente de
De
acuerdo
verdad,
con tus palabras de Betsy. Betsy es un ángel.
Gracias.
Y
de verdad.
de lo que hace por los
Totalmente.
pacientes en el Perú es lindo. Si Margaret tiene mi charla, si alguien la quiere, pásenla. Si alguien tiene preguntas, mándenlas. Cualquier cosa. Un abrazo para todos. Nos vemos. Espero verlos pronto en Perú.
Exacto. Yes.
Hope so.
De nuevo,
Cuídense mucho.
muchísimas gracias a todos y gracias
Thank you so much.
por existir. Un fuerte abrazo.
Ibrahim, it was great
Ibrahim.
seeing you. Martine, thank you so much. Thank you.
Hola, Betsy.
Hola. Adiós. Adiós. Hola, hola. Miguel, ¿cómo estás? David, no sé, no lo veo. I just want to say thank you so much.
Abuelo. Muchas gracias. Hasta pronto.
Ok, hasta pronto. Adiós.
Sí.